Hey,
I don't know if you're all three.
Present. My background is in toxicology. I was a chemist before I went into medicine. I studied poisons. I have done pharmacology, and between medical school and residency, I worked for the Poison Control Center for 3 years in New York City. So the whole reason I got into emergency medicine in the first place was through the toxicology lens. And I just think it's a pretty cool topic. So hopefully we'll keep you entertained and keep you awake for the next couple of hours. My first question to the group is, what is toxicology? Anybody can answer.
The studies of how substances affect the body
Okay. Affect the body
negatively.
negatively. And does it have to be substances? Anything, right? So the study of how anything can potentially affect the body negatively. The word toxic is part of the root of the topic, right? And toxic implies something dangerous or bad. Okay. So a poison is a substance that is toxic by nature, no matter how it gets into the body or how much. That's the definition of something that's a poison. And a drug is a substance that has a therapeutic effect when given in the appropriate circumstance and dose. Can a drug be a poison?
Yes.
Can a poison be a drug?
No.
So one of the first really dramatic drugs that was discovered was from a substance called D-tubocurarine, which is used to stop a person's heart during bypass surgery. And it was discovered from the tips of a poison darts of people from the Amazon rainforest. And so the indigenous people were using it as a poison, right? That's how they would hunt it. They'd shoot something, it would hit the target, the heart would stop of whatever they shot, it would fall from the tree, they would grab it and kill it and eat it, right? So it was a poison in that situation. Yet, we were able to take that same substance, that same chemical, and find a therapeutic use for it, a drug use for it. So a drug and a poison can be the same, but what's the difference? The circumstance of the dose, right? So if the circumstance is you're intubated in a surgical suite about to undergo an operation, and the dose is the proper dose to do what is intended, it's a drug. If I shot you with a poison arrow and you keeled over and died, it's poison, right? They're very closely related. The reason I bring that up is that most of the things that we use as drugs or medications that you find in a household are potentially poisons, right? If you take too much Tylenol, or you take too much aspirin, or you take too much of a beta blocker, or you take too much of any of the drugs in your medicine cabinet, it's probably going to be poisonous or toxic to you at some dose, right? Some things are more poisonous than others. Over 4 million poisonings occur annually, and 10% of ED visits and EMS responses involve some kind of toxic exposure. And a lot of these poisonings are accidental in generally kids under the age of 6. Why? Because they put everything in their mouth, right? If you've ever seen a baby crawling around, whatever they get their hands on goes into the mouth. The taste buds are very sensitive in a child, whereas some other sensations may not be. So they taste their environment. Additionally, about 80% of attempted suicides involve some sort of drug overdose, right? People say they're gonna jump off of a roof or shoot themselves with a gun. That's hard to do, right? To do those actions involves a lot of desire to hurt yourself. But to go into a medicine cabinet and put a bunch of pills in your hand and swallow them, it's a little bit less of a leap to make. And so generally when people are thinking about hurting themselves, they do it in that way. What are the important things that, for you as a provider arriving on the scene, especially in a situation where there may be somebody suicidal or there may be a drug overdose? Is scene safety is always the first priority, right? Make sure that there's no harmful chemicals, make sure that there's no weapons, make sure that the scene is safe. And so you may need to call in law enforcement as a backup to enter the premises before you do. And if you feel that anything is potentially dangerous, then do not enter. And this applies to things like chemical spills as well, right? So toxins don't necessarily have to be medications. Toxins could be a chemical spill from a factory or a plant. So if there are hazardous materials around, then be aware that you may need to call in hazmat or some other kind of organization. There are reference materials, so if you do have to go to the scene of some sort of like factory fire or construction site or something like that, they oftentimes have a guide or a database that's present on scene that's required by OSHA, which explains what kinds of chemicals are present. And so if you're unsure, you can always open up that book and see what chemicals are there. Your other options for getting information include poison control. So the national number for poison control is 1-800-222-1222. You can call that from anywhere in the United States. It will direct you automatically to the closest poison control center. In our case, it would be the Upstate Poison Center in Syracuse. And this is a national network of people who are trained in the specialty of toxicology and poisons, and that often includes pharmacists, nurses who have been trained in this, and emergency physicians who have a subspecialty in toxicology. So if you're ever unsure about something, call poison control. And they can help you in a lot of ways. They can help you determine what a pill is. So for example, if somebody says, I took these white pills, and you're going, white pills, what the hell are they? You know, all the pills have numbers on them. Obviously, it's easy to look it up on the internet, but if you're still not sure, you can call poison control. They'll help you identify them. They'll make recommendations regarding pre-hospital care, and they can also help advise you to what is the best facility to take that person to, depending on what their needs are. You can also always call medical control, and the physician on medical control can help you. What are some kinds of toxicologic emergencies? It may be accidental, right? Like, how many times have you shown up and an older person is confused? Did I take my pills this morning? Should I take them again? Did I take the wrong number? Did I take somebody else's pills? Like, these are dosage errors or medication errors that are completely accidental. Most childhood poisonings are also unintentional, right? The kid isn't trying to commit suicide. They just happen to pull something out of a trash can or find something that fell on the floor and put it in their mouth. A lot of environmental exposures can be unintentional as well, and that can be something as simple as getting stung by a jellyfish, right? That's a type of a toxic exposure. And occupational exposures, people work in hazardous fields, sometimes with very toxic chemicals. And then there can be cases of neglect or abuse where somebody intentionally is giving something to somebody with the intention of harm. There's people who use drugs, shocker, right? People drink alcohol. That's probably the worst drug in the United States. More people die from alcohol than any other drug. And then there's drugs of abuse that we're all familiar with, things like cocaine and PCP and heroin. And then there's unintentional poisonings, which could be, you know, you're unfortunately in a war zone and are exposed to chemical warfare, or somebody is actually trying to cause harm to you. So there's a lot of different ways that you could be exposed to toxins or poisons. there's different ways, routes of exposure, right? Ingestion is probably the most common route of exposure. So you could accidentally drink some household products, like you thought something was a beverage and it turns out to be bleach, right? So that would be an unintentional kind of exposure to a household product. People who are working at home, painting or using chemicals for everyday kinds of projects can also be exposed to things like fumes of ethylene and acetone, so you can be exposed to those kinds of agents. And then there are drugs, plants, and foods that can be ingested. And what you find is a lot of household plants, for example, that are used for just decoration actually contain poisonous compounds in them or toxic compounds in them. And that's the way the plant protects itself, right? It might have sharp crystals, it might have some toxic chemical compound. And that's how we actually discovered a lot of medications or drugs is plants produce these chemicals as defense mechanisms, and humans have found ways to harness them to do good things. There are different kinds of ingestions, and you can have like a caustic ingestion. What would be something that would be caustic? Have you heard that word before?
Bleach.
So
Not bleach.
is bleach an acid or a base?
Base.
Base. So that would qualify. What's something else that would be even more caustic? Yeah, drain cleaners like lye, right? If you were to drink that, that would be pretty bad. So in general, when you ingest something that's toxic, it could cause burns to the tongue, throat, or esophagus, and you can get absorption through the stomach and the intestines. And so some things are absorbed quickly, like liquids. Some things are absorbed slowly, like medications that have an enteric coating. Enteric coating means a delayed release, right? So if you took Tylenol that was enteric coated, it doesn't get absorbed right away. It might sit in your stomach for hours and hours and hours, and could even form something called a bezoar. A bezoar is like a collection of pills that stick to each other and form like a big clump. And so when you have something like that, you may end up having a delayed absorption even up to 12 hours or 24 hours where you could get the toxic effects. Inhalation, clearly inhalation of fumes, for example, like when you go to pump gas, you might breathe in some fumes, but there are fumes that don't have any scent to them. Classic one would be carbon monoxide. So if you were to be stuck in a home with carbon monoxide leak, you wouldn't actually know it, right? There's no smell to it. You would have to have a carbon monoxide monitor to know that there was carbon monoxide. What are some of the symptoms you might experience with a carbon monoxide exposure? Headache, good. Anything else? Flushed, possibly. I wouldn't say that would be a classic symptom. Nausea, vomiting, yeah. So headaches, nausea, vomiting, dizziness, those would be kind of classic symptoms, right? And then you can have actually dangerous kinds of fumes like tear gas. Right? People also inhale things to get high. So nitrous oxide is, what is nitrous oxide? Laughing gas, right? So that can be used as a sedative or a medication to make somebody feel calm, or it can be used to get calm. So again, poison and drug, there's not that much difference. It's dose and use. So obviously with inhalation, whatever the substance is passes through the nostrils, gets absorbed through the pulmonary capillaries and into the lungs, and then goes into the blood system that way. Other routes of absorption can include surface absorption. So if you've ever rubbed up against poison ivy, poison oak, or poison sumac, it doesn't feel great, right? You have blisters and a rash, and it can take even weeks to go away. But there are other kinds of chemicals that also easily get absorbed through the skin, things like organophosphates. And where would you find organophosphates? Pesticides, right. Organophosphates can also be used as weapons. So we'll talk about that a little bit later. But again, surface absorption, absorbed through the skin and into the capillaries and into the bloodstream. Another form of exposure can be through injection. And so obviously we know about a lot of illicit drugs that maybe get injected, but things like bee stings, spider bites, scorpions, a lot of animals like snakes, these basically inject some sort of a venom or a poison into you. And those substances enter the body directly through the skin and oftentimes cause some sort of localized reaction before later getting absorbed into the bloodstream. So what do we need to do? We need to first recognize a situation in which a poison may be involved. If you were to walk into somebody's home and you were concerned about an overdose, for example, what are some ways that you might be able to identify if there was some sort of toxic ingestion or exposure? Track marks, that's good. Pupil size, awesome. Okay, great. Yeah, empty pill bottles. I mean, that would be a pretty key thing to find next to a person. Anything else? A bag of heroin? Yeah, that would be. The person tells you, hey, I injected or took something, or there's a bystander or somebody else in the location. So those are all great ways to get information and figure things out. And I think you hit on a couple things which were really important, which are the vital signs and the clinical presentation, right? What does the person look like? What are their vital signs? And does that give you any clues to a possible exposure? So again, your safety is first, making sure you're in a safe environment when you enter. The ABCs, airway, breathing, circulation. When you first see the patient, you don't go rummaging through their bag of pill bottles if they're in respiratory failure, right? You secure the airway, you stabilize the patient, and then you go look for the pill bottles or the bags or the injection or whatever. Another thing to consider is decontamination. So maybe the person wasn't injecting something, but ended up being exposed to a fire, and there was a bunch of flame retardant that was sprayed by the fire department. And you run in and get the person, and they're covered in this chemical, right? The first thing to do would potentially be, after the ABCs, get all their clothes off, rinse them down, wash them off, reduce the time of exposure. And then there are some antidotes available for certain kinds of exposures, and we'll get into the antidotes a little bit later on. But if you have an available antidote, consider using it. There are things that can be reversed. So size up the scene, do the initial assessment, airway, breathing, circulation, manage any life-threatening conditions, and then consider where you need to transport that person. If the person has a carbon monoxide exposure, and when you find them, they're very altered or semi-comatose or unconscious, what kind of a facility might you want to consider taking that person to? Yeah, somewhere that has hyperbarics, exactly. So not every patient needs to be transported to the identical location. You have to decide what's going to be most prudent and safest for that patient. Obtain as much history physical exam as you possibly can. Try to identify what toxin they have been exposed to and for how long. So if the person says, I took a bunch of Tylenol, did they take it 5 minutes ago, 3 hours ago, 2 days ago? When did they take it? And how many did they take? And did they take one at a time every hour? Or did they take a Costco bottle and chug, 100 pills now? That's all very important kinds of information. And if you do call poison control or your medical control person, those are the kinds of questions they're going to ask. Do the complete physical exam. Document things like pupils, skin. Are they sweaty? Are they dry? Do they have what looks like a rash? Are they flushed? Are they complaining that they can't urinate? These are all like physical exam findings that might help you identify what exactly is going on. And then make sure to monitor their vital signs. Decontamination, super important. We'll talk about some different forms of decontamination. Some of them are pretty commonly used, like activated charcoal or just removing somebody's clothing if they were exposed to something. Some of them have more limited use, like gastric lavage. And some of them are attempts to actually remove the toxin from the body. So things like making a person vomit or whole bowel irrigation. And we'll get into some of that. What is an antidote? Anybody have an idea? Great, I'm glad you can read. Yes. An antidote is something that is a reversal agent. So if you're exposed to one thing, you have a way to reverse it, that would be an antidote. And these are sometimes useful, rarely 100% effective, but used in conjunction with other therapies might reduce the burden of the toxic exposure. So these are some antidotes. I expect you to memorize this screen in the next 10 seconds because it'll be on your exam. Just kidding. Are you familiar with some of these antidotes? I would say the key ones to know would be things like N-acetylcysteine for Tylenol, physostigmine, flumazenil for benzodiazepines. We don't really use the cyanide kit anymore the way that this one is written out. We use what's called the cyano kit. Omeprazole. I'm listing off the ones you should know. So if you're not writing it down, you should be, because these are the ones you're probably going to be tested on. Naloxone, you guys familiar with that one? So I would say those are the big ones. I'll repeat my list.
Okay, good.
N-acetylcysteine, flumazenil, cyanocobalamin, which isn't up there, but that's the cyanide cyano kit. Naloxone, omeprazole, and atropine. Let me know when you're ready. On. General treatment. Suicidal patients, you want to make sure to secure the scene, get law enforcement involved, contact your medical control. When you're doing your assessment, what are the questions you should be asking? What was ingested? When was it ingested? How much? Was there alcohol involved? Did the person try to treat themselves? Are they under psychiatric care? And what is their weight? And these are important questions because depending on the toxin, if you were to call poison control, they would want to know how many pills, what's the dose, and how much does the person weigh? Because they're going to do some calculations to help you decide, was this a poison or toxic exposure or was it not, right? Some things are super toxic, some things not so much toxic. So for example, a toxic dose of something like Motrin or Advil is about 30 grams. That's generally 60 plus pills. It's really hard to swallow 60 pills, right? So if somebody takes 4 Advil or 5 Advil, it's unlikely to be toxic. But there are other substances where if you were to take 2 or 3 of them, like lithium, that could potentially be quite toxic. So knowing the dose, knowing how much, and knowing how much the person weighs are important factors. The physical exam we talked about, do a head-to-toe physical exam. If there's nothing else that I get across to you today in this lecture, it's that your physical exam matters and the vital signs matter. And so when you're taking a lab here or getting quizzed or presenting a case, I don't want to hear the physical exam was there's no trauma to the head and that was your physical exam, right? Your physical exam is a head-to-toe physical exam. What did their skin look like? What do their eyes look like? What does their oropharynx look like? What's their respiratory status? What is their heart sound? What is their circulation? Do they have abdominal distension? Is it tender? Like these are all the things that you should be describing when you're doing a physical exam. And when you are being tested and the person asks, what does the patient look like? I want you to think about, how do I do a head-to-toe physical exam? Because unless somebody is in respiratory failure or cardiac arrest where you need to do the ABCs first, if they're somewhat stable, you need to do a physical exam, okay? And then, was there an exposure to multiple toxins? So for example, did they take every pill bottle out of the cabinet? Or were they experimenting with drugs? Like, those things can interact with each other. Other things to think about: is the person altered or obtunded? Is there a chance they might vomit? You want to try to prevent aspiration, sometimes giving them an antiemetic like Zofran, or turning them on their side if you think they're going to throw up. Give them some fluids. If you have some sort of reversal agent like Narcan, give it. And then decontamination. Get them on an EKG. EKG is super valuable. You can learn a lot from an EKG about certain toxic substances. Vital signs are important. And although you may want to, try not to induce vomiting. Why? What would be bad about inducing vomiting in the patient? Aspiration, right? Like you might get 3 pills out, but if they aspirate, you've just taken a stable situation and made them unstable. And so there may be a few cases where making the person vomit will make sense, but that should be done in consultation with the physician or poison control. And usually if you're very far away from a medical center, so if you're in rural Iowa and the closest hospital's 100 miles away, it may make sense to induce vomiting in somebody if it's going to change the outcome. But in almost all cases, it doesn't make sense. So don't do it. I'm going to move on here. So, toxidromes. What are toxidromes? Toxidromes are when similar groups of poisons or harmful agents have cause similar symptoms. And sometimes it may be difficult to identify exactly what the person took, but using the keys and the clues from a toxidrome might give you an idea, even if you don't know the exact drug. And so the first toxidrome is an anticholinergic toxidrome. Is anybody familiar with the word anticholinergic? Have you heard that before? So what would be a very common kind of medication that would cause anticholinergic symptoms? Okay, yep. Atropine, but I'm not sure how common that is. I don't think most people have atropine lying around in their medicine cabinet.
Benadryl?
Scopolamine, maybe. I mean, if you have a history of vertigo or dizziness, you might have scopolamine patches. The most common one.
Benadryl?
Benadryl. Yeah, antihistamines. Everybody's got antihistamines in their medicine cabinet, right? You've got allergies, a runny nose, you got a rash. So things like antihistamines fall into this category. I would say the second most common thing is going to be the tricyclic antidepressants. So those two are the most likely ones that you're going to find that are going to cause some anticholinergic symptoms. And the anticholinergic symptoms, There's a way to remember them. Is anybody familiar with the sort of saying of cheat sheet? Say it out loud. Sludge is, I don't know if that's the right one.
Wrong one.
Try
Drawn up as
again.
a hare, drawn as a
Oh.
hawk, red as a bee, blind as a bat, and mad as a hat.
Beautiful. We're all going to say it together. You guide us.
Hot as a hare,
Hot as a hair. Everybody, hot as a hair.
dry
Dry as a bone.
Dry as a bone.
Red as a bat.
Red as a bee.
Red as a bat.
Amen.
All right. So what is that mnemonic?
Yeah.
What is that mnemonic teaching us, right? When you see a patient and they're flushed, their skin is dry, they're complaining of being very thirsty, their pupils are dilated, their heart rate may be increased, their temperature might be elevated, they complain that they can't urinate, they may be very confused. These are the hallmarks of an anticholinergic overdose. And I've seen it happen so many times where there are also some psychiatric medications that have anticholinergic effects, like the tricyclic antidepressants. You have a psychiatric patient who comes in and they're sitting in the stretcher, and you're like, I got to get some urine to do a drug screen. You give them the cup, and they come out of the bathroom, and it's empty. You give them a bunch of fluids, and you say, go give me some urine, and they come out of the bathroom, and it's empty. And you're like, this doesn't make any sense to me. I gave the person 2 liters of fluids. There's no way they don't have to pee. And when you talk to them, they say, I've tried, I went, I can't go. And you put an ultrasound or a bladder scan on them, and they have 1,000 cc's of urine in their bladder. One of the side effects of anticholinergic overdoses is it affects some of the muscles that have to do with the squeezing and relaxation of the bladder. So when I've seen that, I go, oh, now I get it. You took too many, whatever they were, and then they will say, yes, I did. So maybe try to overdose on Benadryl. The worst case scenario is altered mental status. So if you have somebody who's anticholinergic, who is actually delirious or completely altered, not making any sense, sometimes they get so hot and flushed they rip their clothes off and they run around naked. That would be a person who you would be really worried about, right? The next toxidrome is the acetylcholinease inhibitors. So what is acetylcholine? Anybody familiar with that? Yes, no, don't be shy. A neurotransmitter, beautiful. So when your neurons are speaking to each other, there's receptors and there's neurotransmitters. And those neurotransmitters get released from one neuron, they go across and they get hit on a receptor and they send the signal down the next neuron. And so when your body is trying to send signals, it uses acetylcholine to send those signals. Now, if you were to take something that caused a reduction or a blockage in the acetylcholine that was being transmitted from one neuron to another neuron, that might cause a problem, right? What if you were trying to send a signal to your muscles to start running away, and those signals weren't making it to the muscles? What would happen? What? Faceplant, right? You'd have weakness, generalized weakness. What if it was to the respiratory muscles of your diaphragm? Respiratory failure, right? Like if your diaphragm is stunned, it's weak, it's not moving, you're not breathing. And so there are people who have decided that organophosphates, not only are they really good at killing pests and plants, but they're really good at killing people. And so things like Agent Orange, which was used during Vietnam, are in this class of chemical because they would spray it over an entire forest, and if you inhaled it and breathed it into your lungs, you would have a bunch of symptoms, which we're going to talk about in a second, and you probably have respiratory depression and generalized weakness, and then you just become paralyzed and fall over and die. And it was a very rapid, horrible, ugly death. So I think you brought up some symptoms mistakenly about anticholinergics. Do you want to read me those? That you...
Yeah. GI distress.
Three B's: bradycardia, bronchospasm. What's the other one?
Korea.
So sludge, which is the mnemonic for the acetylcholinesterase inhibitors, it's almost the opposite symptoms of the anticholinergics, right? The anticholinergics, you're dry, you're flushed, you're tachycardic. If you were to think of what's the opposite of that, you'd be sweating, vomiting, bradycardic, small pupils, instead of urinary retention, urinary incontinence. So these are like two opposites of each other, right? The acetylcholinesterase inhibitors and the anticholinergics are like diametrically opposed. So that's one way to remember them. Just don't mix them up. So the mad as a hatter, hot as a hare, that mnemonic goes with the anticholinergics. Sludge goes with this one. Any questions about that? Okay. So cholinergics are similar to the acetylcholine inhibition that we just talked about with similar symptoms. And if you think about the first thing that we talked about, which was what? Anticholinergic. What does the word anti mean? Opposite, right? Opposite of cholinergic. So that was one toxidrome. So cholinergic is probably the opposite of anticholinergic and similar to acetylcholinesterase inhibition. So the cholinergics are things that increase acetylcholine and cause the same symptoms: sweating, vomiting, sludge, cause sludge symptoms. And in some parts of the world, they chew a plant product called betel nut. Have you ever heard of that? Have you ever seen a documentary where there's like people, for example, in Africa or South America, and all of their teeth are black? It's from the betel nut. And so they will chew this to get some, almost like a high off of it. But if you chew too much of it, you get all the bad side effects. So in plants, it's generally in low concentrations, and so they chew the plant material, they're getting a little touch of it. Whereas, there are medications, for example, like muscarine, where you would be exposed to a high dose of it, and it could be very toxic. There's another group of toxidromes that are called extrapyramidal side effects, and this is really like a unintentional side effect of a lot of psychiatric medications. So if you've ever seen the psych patient who is licking their lips, rolling their tongue, they keep having these like unintentional movements of their hands or arms, it's not because they want to do that. It's because they've taken too much of their medication, and it's caused changes in the neurotransmitters and receptors in their brain. And so things like Haldol especially can cause these. And it doesn't necessarily take a lot of doses of something to cause it. You could have a first-time exposure to one of these medications and have these symptoms. So for somebody who's been naive to a medication, meaning they've never been exposed to it, I've definitely seen cases where we've given a patient Haldol, for example, and they became rigid, like almost couldn't move. Their muscles like locked up. and it was a side effect of the medication that was unintentional. The hemoglobinopathies are a group of toxidromes that are related to mostly inhalation. The main one that you should be aware of is carbon monoxide. There is another one called methemoglobinemia that usually is due to some exposure to a fire, whereas carbon monoxide is usually fumes from burning something like an HVAC system or a boiler where the gases are not contained and are being released. And carbon monoxide also causes symptoms similar to the cholinergic toxidrome. So nausea, vomiting, headache, dizziness, all of those things that we discussed. Don't count carbon monoxide out. When I worked for poison control, people would call with symptoms that sounded like food poisoning. They would say, I really don't feel well. I've been vomiting for 2 days. I have a bit of a headache. My stomach hurts me and I feel nauseous. And then you would say, like, oh, did you eat something that didn't really sit well with you? Or does anybody else that you live with have the same symptoms? And they'd say, oh, yeah, like everybody in my family has the same symptoms. And then you're like, okay, did you eat like some bad egg salad or some, chicken that was left out? No, we didn't do anything like that. And then you'd say, well, have any alarms been going off in your house? And they'll be like, oh yeah, there was that annoying beeping and I took the battery out because I thought the smoke detector went bad. And it turns out that there was carbon monoxide poisoning and the whole family is exposed, right? So think about it in the back of your mind when you enter a scene and you see a lot of people who maybe look like they had some food poisoning symptoms. Maybe it's carbon monoxide. How would you actually test to find out if somebody had carbon monoxide in their system?
The fire people carry this monitor.
Right, so the fire department has monitors, so if you ask the fire department to come to the scene, they can actually check the carbon monoxide level. What did you say? I'm not familiar with what that is.
That's what they're called.
Oh,
The
same
rest.
thing. Okay, so like a carbon monoxide monitor. Got it. So in the emergency department, we can actually check the level in the blood. So we take a blood sample, and just like you would get a blood gas, you can check for things like the oxygen level, the carbon monoxide level, the carbon dioxide level, but you have to ask for what's called co-oximetry. Co-oximetry looks for these hemoglobinopathies, so sulfhemoglobinemia, methemoglobinemia, and carboxyhemoglobin, and it can actually give you a level. So for a patient who actually you check their level in their blood and it's 20% or higher, those are patients who need to get hyperbarics. And those patients should go to a hyperbaric capable facility, usually a big teaching hospital like Jacobi or Westchester or Albany. Community hospitals don't have hyperbarics. So you probably need to bypass the community hospital to get to a bigger teaching hospital. Who knows about narcotics?
Drugs. Drugs.
Yeah.
In any way, shape, or form. What are some of the symptoms you might experience if somebody had a narcotic exposure? Right. Respiratory depression and potentially hypo or hypertension is possible.
Fixed or dilated pupils. Like
Yeah,
pinpoint or dilated pupils.
I wouldn't say so much dilated pupils. I mean, definitely pinpoint pupils would go along with it. Bradycardia, sure. Yeah. Is there mental status grade?
Nope.
Probably depressed a little bit, right? It's a depressant. And what would be your antidote for a narcotic?
Narcan.
Narcan, right? Everybody's got Narcan. You've got Narcan, the mom's got
Narcan, not
Narcan,
Narcan.
police have got Narcan, fire's got Narcan, and we love just spraying it everywhere, right? People come in now, oh, I gave them 12 of Narcan. Okay, well, did the first 2 of Narcan work? Yeah, they woke right up, but I just kept squirting some more. On the other hand, there is something in cocaine these days, which is fentanyl. And with fentanyl, you might have to give 12 of Narcan to wake them up, right? Fentanyl is way worse than heroin or over-the-counter or pills or Percocets or oxycodone or any of those. So in that case, you might need to get a lot of Narcan. What is another long-acting, high-dose narcotic that you might encounter? Dilaudid, yeah, but probably not that frequently. I don't think there's a lot of people walking around with Dilaudid. Heroin, I'm talking about something more common that we give patients. They might go to a clinic to pick it up every day at 7 a.m. Methadone, right? Methadone is generally a very long-acting narcotic. It can be up to 24 hours in your system. That's why you take it once a day. And the doses they're on are crazy, crazy, crazy doses, right? Like 270 milligrams of methadone. And if they don't get it, they go bonkers, right? Because the withdrawal from opiates is bad. You know, if opiates make you feel good, you're high, you're chill, you're calm. The opposite of that when you're in withdrawal is you're vomiting, you're diarrheaing on yourself, your skin is, all your hairs are sticking up, your pupils are dilated, you feel terrible. And so that's why people who are on methadone, for example, if they miss even one day at the clinic, are like straight to the ER because they feel like crap. Sympathomimetics, this is another important toxidrome that you should be very aware of. And it's all the things that cause you to feel sped up. And so the common things you might counter would be our favorite drug of all, caffeine, right? Or for some of us, maybe cocaine, I don't know. I've never tried it personally, but I imagine it makes you feel pretty good. Another thing that a lot of folks might be on are ADHD medications. So things like Ritalin, methylphenidate, those you would pretty commonly encounter, right? For some reason, in Poughkeepsie, cocaine is cheaper than almost anything else. I don't know how it is or why it is, but I've seen a huge uptick in cocaine exposure. Unfortunately, they cut most of the cocaine with fentanyl. And so people who think they're getting cocaine are getting a big dose of fentanyl and oftentimes don't survive that. Pathomimetics are things that cause your whole system to ramp up. So if you were to think about things ramping up, your blood pressure would be going up, your heart rate would be going up, and your neurons are firing faster. And in your brain, if your neurons are firing too fast, you're probably going to have a seizure. So the biggest problem with these kinds of medications is slowing their heart rate down and controlling for seizures. So it's not uncommon. People come in with chest pain after cocaine, and their heart rate is 150 or 160. And the other thing that cocaine does is it squeezes your blood vessels. So if I take your heart rate and I push it up to 150, and I squeeze all the blood vessels carrying blood to your heart muscle, what do you think is going to happen?
Good night.
What happens if you cut off the blood supply to the heart? A heart attack, right? So we kind of poo-poo these patients oftentimes. We're like, oh, you're just high on cocaine, and we give them something to try to bring their heart rate and blood pressure down. But in reality, they cut off the blood supply to their heart, and they're having a heart attack. And so anybody who I think might be on cocaine, the first thing I'm checking is an EKG. Are they having a STEMI from their cocaine, which can happen? And I'm checking their heart enzymes to make sure that their heart isn't damaged. Anybody familiar with the drug phentermine? Yeah, tell me about fen-phen. What happens now? Yeah, so this was back in like the early 90s, I want to say, a weight loss. Yeah, a weight loss drug that was being sold over the counter because it was making people lose tons of weight because you never were hungry, right? What's that?
Is that similar to Ozempic now?
Nothing like
No,
Ozempic.
Oh, never mind.
But the problem with fen-phen or fenfluramine, phentermine was it caused cardiac arrhythmias. And so people would take it to lose weight. Young people, we're talking like people in their teens and 20s, would take it to lose weight and would have massive cardiac arrhythmia and drop dead. So that didn't go over too well. The next one is sort of the opposite. So when we're talking about toxidromes, we're talking about what happens when you take something. So when you take caffeine or cocaine, or when you take, when you're exposed to a toxin, withdrawal is the opposite. So whenever somebody is in withdrawal, you want to think about the opposite symptom. So what happens when you drink a lot of alcohol? Do you run a marathon?
Slow down.
No, you probably feel really tired, right? You feel a little bit chill, you feel super calm. If you drink too much of it, you probably pass out. So if you're somebody who's addicted to alcohol or habituated to alcohol and it starts to come out of your system, how do you feel? Do you feel chill and calm? Right? You feel shaky, you feel anxious, you feel like you got to get up and move because it's the opposite. So the withdrawal from whatever it is makes you feel the opposite. So what does the withdrawal from cocaine look like? When I see somebody coming off their cocaine high, they're asleep like that. Halfway off the stretcher, fast asleep, right? Because they're experiencing the opposite of what that drug was doing. If you're in benzodiazepine withdrawal, what do you think you look like? Right, really jittery, right? The patient comes in, they say, I take 10 Xanax a day to calm my nerves, and they come in because they ran out of their Xanax. They're jumpy, they're hyper, they're talking a mile a minute, right? Because they're in benzodiazepine withdrawal. So when something is a sedative and you're withdrawing, it makes you hyperactive. And when something makes you hyperactive and you're withdrawing, you're getting sedated.
I've seen that, like, I know a lot of people that have withdrawn from benzos, but they'll, like, need to do something. So, like, jittery.
They're jumpy, right?
They'll come over and, like, in the whole house.
Your
Can I
house.
borrow them?
Yeah.
How do I find that?
I just call the
So we talked about the cholinergics, the sludge, the bradycardia, the bronchoconstriction, the wheezing. What's something that mimics the cholinergics? We talked about this. Pop quiz. Acetylcholine inhibitors, right? Management is decontamination. And there is actually reversal agents for cholinergics. So when we were talking about the cholinergics, those included the organophosphates and the nerve agents. And the decontamination is important, but the reversal agents are atropine and a drug called pralidoxine or Tupam. And so oftentimes in the military, people would actually carry Tupam on them so that if they were exposed, they had the antidote available to them. Other things would be reducing the chance of seizures, so things like Valium or diazepam, and transporting the person to the appropriate facility. Going to quickly touch on cyanide. Where might you find cyanide?
Apple seeds.
What's that?
Apple seeds.
Apple seeds, 100% correct. Spy movies, right? If you're a Russian spy and you're trying to take somebody out. Common places.
Peach pits.
Factory.
Right, so anything that's related to a cherry is like
I'm
a
just kidding.
apple, cherry,
All those
nectarine,
pits have.
apricot. They all have cyanide in the pits. But where else? Artist studios and some of the paints. Yeah. So the most common thing is going to be in synthetic fibers. And when a house is on fire, there's a lot of synthetic fibers, right? You got the couch, the rug, the wallpaper. Like half the shit in your house has probably got some sort of cyanide compound in it. And so most of the time, if we're concerned about a cyanide poisoning or exposure, unless you're a spy and somebody's trying to take you out, then, or you're trying to commit suicide because you are a spy, then it's probably a fire exposure. And so when somebody comes in and their cherry red color and their oxygen is low and their mental status is altered and they might have a headache or confusion, you might want to consider the antidote, which is what? The cyano kit. Most commonly now we use cyanocobalamin. Cyanocobalamin is a vitamin, so it's non-toxic. So the cyanocobalamin, the color of it is bright red. The problem if you give somebody the cyanocobalamin, which is given through the IV, is it turns the person's blood bright red. And the way most of the labs work in a hospital, when you send the blood down there, is they use spectrometry. They shine a light through the blood, and the scanner scans the wavelengths that pass through the blood, and that gives you a lot of the data. How many red blood cells, what's their size, how many white blood cells. But if you dump a bunch of Kool-Aid into somebody's bloodstream and you shine a light through it, now all the readings come out false. So one thing that I recommend is if you do ever decide that you're going to give somebody cyanocobalamin, is try if you can to get a blood sample first that you can send to the lab, because once you give this, all the labs are going to be wrong. So it may not be feasible, it may not be possible, but something to consider. Problems with cyanide, super fast acting. How does it work, or where does it work in the body? Anybody know? More specific, I'm talking at the cellular level.
Mitochondria?
Thank you, mitochondria. What happens in the mitochondria? The powerhouse of the cell. What does that mean?
Oh,
What
I know what the
happens?
mitochondria does, I just don't know what it
What does it do? You said you know what it does. What does it do?
What is the mitochondria?
Oh, it packages proteins, right? No, yeah, the powerhouse of the cell.
What does that mean?
It makes hold on a second. No fluster.
What is the energy carrying molecule of the
Oh,
cell?
ATP.
ATP, right? Adenosine triphosphate. So in the mitochondria, it strips electrons off of oxygen, which is what's carried in your blood, and it goes into the mitochondria and it passes those electrons off onto ATP, which then get carried around in your body to power your body, right? So if you put something in that electron transport chain that blocks it, the electrons from oxygen don't get to be transported off onto make ATP. And so you're essentially shutting the person's body down because they're no longer making energy. If you have blocked all the mitochondria from making the energy source of the body, now the cells are dying, and they're dying fast because your cells need energy constantly for all of the other functions like making proteins, clearing out toxins, moving electrolytes back and forth across the membrane. If you don't have energy to do that, you die. And so it's super fast acting, it's super toxic, and you want to try to reverse it if you can. Again, the dose is the poison. If you take a capsule of cyanide, you got like a couple of minutes before you're dead. If you're exposed to some cyanide fumes from a fire, you probably have some other symptoms first, like headache, confusion, tachycardia. You might even have a seizure. You're probably not going to die instantaneously. you have some time to get to the hospital. The management, make sure that you as the rescuer are safe. If you're running into a burning building, you yourself could be exposed to cyanide, so be careful. There are different kinds of antidote kits. So there's the cyanide antidote kit, which has 3 different components. It's very confusing. You have to give them in the right order. And if you screw it up, it doesn't work. There's the cyano kit, which is hydroxycobalamin or vitamin B12. Almost impossible to make a mistake or screw up. You give the 4-gram dose, and you're done. So if you had to choose between the two, which would you choose? The cyano kit. Well, it turns out the cyano kits have been off the market for the last 2.5, 3 months because the manufacturer of them, they realized they were all contaminated. And so there was about a 3-month window where we had no cyano kits in any hospital. We had to go back to the old cyanide antidote kit, which nobody remembers how to use anyways. And luckily, I didn't have any cyanide poisonings in the last 3 months. But I was just informed yesterday that cyano kits are coming back onto the market and the FDA has approved them again. But all the ones that were contaminated are still out there. So just be careful.
Did they say what they were contaminated?
I don't remember. I think there was like bacteria in the bacterial contamination. So people were getting like septic.
Oh, well, you know.
You know.
We'll save you from the cyanide, but we'll give you
We'll give you
sepsis.
bacteria.
So slow death versus quick death.
Chlorine. Have you ever been exposed to chlorine? What's the common place that might happen?
The pool.
Your pool, right? You're going to dechlorine or put chlorine in your pool, and you open up the box or the bag in an enclosed space, and you breathe a bunch of the fumes in. Does it feel good?
No, I've done that a bunch of times because I left mine out when it rained, and then when it got wet, you open it up,
Yeah.
it burns.
Yeah, it burns, right? You breathe it in, and your lungs feel like they're on fire, and your eyes are burning, and your nose is burning. It causes basically like a chemical burn to your mucous membrane. Another place that you might be exposed to chlorine is if you combine a bleach and an acid, they form a compound called chloramine, which is volatilized into the air. And so a lot of cleaning products are not meant to be used together. So toilet bowl cleaner is a very strong acid. Lye is a very strong base. If you happen to throw the two together, it forms a chemical reaction, giving off hydrogen and chloramine. And if you happen to be the cleaning lady standing over the toilet bowl when that happens, you can pass out. So in this little thing here, it says, Miss Robbins, there really is such a thing as too clean a toilet. And we got quite a few calls for this kind of an exposure at poison. What happens? You get coughing, burning sensation. You might even become hypoxic or cyanotic. And for severe exposures, we're talking about like chlorine gas in an enclosed place. You can go into shock or have seizures. So the treatment is really get the person into fresh air. Like that's step number 1. Step number 2 is decontaminate. So get off all their clothes, wash them down with fluids, give them fluids, give them oxygen, try to decontaminate. Carbon monoxide, we talked about already. Get the people out, right? The treatment for carbon monoxide exposure is oxygen. So get them out. And then give them the highest concentration of oxygen you have, whatever that might be. High flow nasal cannula, non-rebreather, scuba tank, whatever you happen to be carrying with you that's oxygen, that's your treatment. So again, remove the person. Oops, I went the wrong way. Make sure you're safe. Get the person out of the area. If the fire happens to be there, measure the carbon monoxide levels, and if you can, measure the levels in the patient, and then consider hyperbaric oxygen treatment if the levels are very high. There's different kinds of hyperbaric chambers. You have these single individual person chambers like the one that's pictured here. Those are oftentimes used for divers. So like if you ever get the bends, that's too much nitrogen in your bloodstream, you would have to go into a hyperbaric chamber to essentially dive back down under the water in the chamber and repressurize the nitrogen back into your bloodstream and allow it to come out slowly. With a hyperbaric chamber and carbon monoxide, what it does is it forces the oxygen onto your hemoglobin. So it displaces the carbon monoxide with oxygen. And your blood cells like oxygen, they don't like carbon monoxide. So it essentially is the change in pressure is what allows that to happen. Cardiac medications. Does anybody in the United States take cardiac medication? Nobody. Everybody, right? If you're like me and old, over the age of 45 or 50, probably your blood pressure's starting to go up. Probably you've got some other medical issues like high cholesterol. Maybe you've even got heart failure or diabetes. And so your doctor is most likely going to put you on some kind of medication to control those things. And does anybody in the United States use diet and exercise to control any of these things?
Something enough.
Sometimes, but rarely. Do they use Ozempic?
Yes.
Everybody's using Ozempic. Right. So the major classes of cardiac medications are the beta blockers and the calcium channel blockers. Those are the two most common because they're effective and they're safe, generally safe. There are other kinds of medications like the angiotensin receptor blockers or the ACE inhibitors, and those affect blood pressure as well, also generally safe. Those act on the kidney rather than on the heart. There are some kinds of cardiac medications not so safe, and these are the antidysrhythmics. So people who have very irregular heartbeats, we put them on medications to try to control their heart rate and their heartbeat. And in general, those medications can cause irregular heartbeat. So the same medication that controls your heart rate can cause you to have an irregular heart rate, or heart rhythm, excuse me. And so if you're a little kid and grandma or grandpa happens to be on one of these medications to control their heart rhythm because they have a heart block or something like that, and the kid who weighs, I don't know, 10 pounds, 12 pounds, sticks it in their mouth, and the dose is intended for an 80 kilogram or 70 kilogram person, what do you think could happen? Yeah, the kid's going to have some kind of cardiac dysrhythmia, right? And if the kid's dysrhythmia happens to be it has a sinus pause for 30 seconds, is that going to be good? What if the dysrhythmia is it goes into an irregular ventricular rhythm? Is that good? So there are kinds of drugs or kinds of medications where one single pill can be dangerous. And generally we're talking about in kids. There's not a lot in adults who are normal size and weight where one taste or one pill or one sip of something can really hurt you. But in kids, in particular, cardiac medications can be very dangerous. And so don't joke around. If grandma or grandpa's missing some pills from their bottle and the kid thought they were Skittles and popped it in their mouth, whether you think they swallowed it or not, whether you can find it or not, that child needs to be evaluated in a medical setting. You probably need to call Child Protective Services. Most commonly, cardiac medication errors are due to dosage errors. So grandma or grandpa took one extra beta blocker. Generally not a problem. Like most of these drugs are pretty safe, and if you took one extra one, maybe your blood pressure is a little bit lower, maybe your heart rate's a little bit slower, but generally not a problem. If you intentionally take a bunch of them, that's a problem, right? You could have profound low blood pressure, cardiac dysrhythmias, bradycardia, heart blocks, cardiac issues causing pulmonary edema, fluid to build up in the lungs. Those are patients who need intensive immediate care. And we do have ways to reverse some of the effects of these medications. So if you know somebody intentionally took a beta blocker or a calcium channel blocker, some of the antidotes or reversal agents for those are things like glucagon. Glucagon works through a completely different pathway to increase the heart rate and rhythm. So if you're blocking the heart rate and rhythm through the beta blocker and you give glucagon, it's not that it's reversing the beta blocker, it's just allowing the heart to pump faster and stronger through a different pathway. But it essentially works like an antidote. If you take a calcium channel blocker, what does a calcium channel blocker do? Blocks calcium. So if you give the person more calcium, you might be able to overcome the blockade because there's more calcium present. So for things like beta blockers and calcium channel blockers, we will often try glucagon and calcium to reverse the effects. We talked about some caustic substances. What does the word caustic mean? Your Latin.
It causes damage to tissues.
That's a good guess. Caustic means burn, right? So these are things that cause some sort of a burn, oftentimes by touching your skin or by ingestion. And so you have acids. Acids have a very low pH. What's something that might have a low pH? Anything. Hydrochloric acid, right? Anybody ever heard of a lemon? Right? Lemons. What else might have an acid in it? Batteries, right. Like, so these are places where you might come in contact with a fairly strong acid. And acids in particular cause what we call coagulation and necrosis. What does coagulation mean?
Clumping together.
Clumping together, perfect. Right, so if you were to ingest an acid and it were to go down your esophagus and be exposed to all those proteins and tissues, it's probably going to cause those tissues to clump together to form a big, like fibrous mass or something like that. Whereas the alkalis, these are strong bases. These are things with very high pH. What's a strong base? We talked about a few of them. Lye, bleach, right? Things like that. They usually feel soapy because what do? What is a soap?
Slippery.
Why does something feel slippery? What's underneath your skin, the top layer of your skin? What's adipose tissue? Fat, right? So underneath your skin is fat. And when you use soap, which is a base or an alkali, and you rub it on your skin, what is it doing? Not absorbing the fat, the opposite. Not absorbing the fat. It's melting fat, right? It's taking the oils and the fats in your skin, and when you rub the soap or the base on there, it's literally melting them, and that's what makes it feel slippery. Have you ever accidentally taken Clorox bleach and spilled it on your hand, and you're washing your hand in the water, and it's just like it keeps feeling slippery, and you're like, it doesn't come off? It doesn't come off because it's the fat in your skin that's melting, right? So bases cause what? Liquefaction. Liquefaction is to turn something into a liquid. So if you were to drink a bunch of really strong lye or bleach, what do you think is going to happen? Is it going to clump together? What's it going to do? Liquefy your tissues. Literally turn them into liquidy mush, right? So if you had to drink something accidentally, would you prefer to drink an acid or would you prefer to drink a base?
Acid.
An acid, right? Do you drink lemon juice?
Yeah.
Yeah, we put it in our tea. Do you drink bleach? Probably not, right? So our body can handle acids much better than it can handle bases because what's the pH of your stomach? Probably like 2.5, 3, right? You have strong acid in your stomach. Has anybody ever had acid reflux? It burns, right? Do you die? Does your esophagus melt?
No.
No. Right. What's the treatment for acid reflux?
Nope.
Tums. What's Tums?
Antacids.
What's Tums?
It's an antacid.
Calcium carbonate. What's calcium carbonate? A base, right? So if you take an acid and a base and you mix them together, what do you get? Neutral. So it neutralizes it, right? So when you're taking Tums, you're literally taking calcium carbonate, which is basically the shell of a mollusk or a clam or whatever, right? That's calcium carbonate. And you're taking a base and you're putting it in with an acid, and you might burp a little bit and feel some rumbling in your tummy, and all of a sudden the burning goes away because you neutralize the acid. So if somebody's exposed to an acid, what might you consider doing? Giving them a base, right? So for example, if somebody were to expose their skin to a really strong acid like hydrofluoric acid or hydrochloric acid, you could potentially take calcium gluconate, which is a base that you have available, and put it in some liquid or some gel and stick the exposed body part into that. And the acids and the base will neutralize each other. So whenever you're dealing with acids and bases, consider, is this something I can neutralize, right? What do you think this guy got exposed to? An acid or a base? It melted his cornea, right? I don't know what the hell he put in there. Something not good. So caustic substances, you have to really be careful about the airway. So if somebody were to have ingested something acid, very strong acid or base, be concerned about drooling, trouble swallowing, change in voice, difficulty breathing, vomiting. These are patients where you really have to control the airway. I mentioned before that there's a way to decontaminate something called activated charcoal. We use activated charcoal to absorb organic compounds in the gut. And so what is activated charcoal? It's literally charcoal, like the same thing that's in a brick of charcoal that you would cook on. Your fish tank filter has charcoal in it. Charcoal is a very absorbent material. Now, if you had somebody who swallowed an acid or a base, what color is charcoal?
Black.
Black as night, right? And that you're going to bring this person to the hospital. Would it be a good idea to give them activated charcoal to drink? You're worried about them having burns or necrosis or something to their esophagus or their airway. Yeah, so if you're a doctor, the first thing you're going to do is either intubate the person, or you're going to call the GI doctor to come and scope them and put a camera down there to see what the damage is. If you gave the person a big old vial this big of black and they drink it, nobody's seeing anything. And on top of that, they have the risk of vomiting, and so they can aspirate. So in general, we try not to give activated charcoal, number one, for anything that's a liquid, because activated charcoal doesn't absorb liquids. And number two, in any situation where there's an acid or a base ingestion, because it's going to obscure the airway. Hydrofluoric acid, what's that used for? That one's tricky. It's used for graffiti removal. So if you've ever seen like graffiti on a brick wall and they're trying to get it off, they spray it with hydrofluoric acid and it literally just like melts it off. If you've ever tried etching glass, hydrofluoric acid is used to etch glass. Very, very, very strong acid. And as we talked about before, acids and bases like to link together. And acids are generally negative charge. There's something in our body that's very positively charged, which is calcium. Where's calcium found? Bones. Your bones are all calcium, right? Calcium in different crystallized forms. So if you actually get hydrofluoric acid on your skin, not only does it go through and penetrate through the skin and melt the fat, it goes straight into the bone and starts to absorb into the bone where it's trying to fuse to calcium in your bone. And when you mix an acid and a base together, you get a reaction, right? Because they try to neutralize each other. So hydrofluoric acid is really, really, really bad. And one of those things that I talked about before is adding calcium externally somehow to try to absorb as much of that hydrofluoric acid. So in cases where people have sprayed it on their hand, for example, or spilled it on their hand, again, we can put calcium gluconate into a solution and stick their hand in it, and the hydrofluoric acid will try to bind to the calcium that's outside of the body. But it causes severe burns. For most acids and bases, the first step is going to be decontamination, so get the clothes off, and irrigation. Try to immerse the body part in water, try to dilute it. If they swallowed it and you're not concerned that their airway is compromised, you could have them drink some water. But dilution is the solution for acids. Hydrocarbons. This is a totally different type of ingestion. Oftentimes intentional, but not always. Has anybody heard of people sniffing, let's say, aerosol cans of dust off? Or you like to open a can of paint and breathe it in because it smells good? Or how about when you were a kid, the Elmer's glue?
Yes.
Or maybe some lighter fluid, right? Why do these things have an effect on our body? These hydrocarbons are very, very, very small molecules. Small molecules, when they enter the body, can cross the blood-brain barrier. So things like a hydrocarbon actually goes into your brain and directly affects your brain and your nervous system. So when you're inhaling these, whether it's intentional or accidental, if it's accidental, you might feel dizzy, you might feel nauseous, you might have some blurred vision, or you might feel high. If it's intentional, you could actually overdo it to the point where you pass out and seize and die. So I remember a case when I was working for poison control. There was a dentist who was found by the cleaning woman in the building at the end of the day, completely passed out and unconscious in the dental chair with a mask on his face. What was he doing? Nitrous. He was getting high off of his own laughing gas. The nitrous, like a hydrocarbon, is a gas, and it crosses the blood-brain barrier. And in his case, it caused him to basically go into a coma. So these are things that very easily affect you, very quickly affect you, generally wear off very quickly too. So problems with hydrocarbons, headaches, dizziness, slurred speech, unsteady gait, those are common. Cardiac dysrhythmia is a little bit more uncommon. Methyl alcohol. Where do we find methyl alcohol? Most common place.
Antifreeze.
Usually acetone, but could be. So the most common places are the windshield wiper fluid they use in the winter. So if you've ever seen the different color windshield wiper fluids, and there's like summer and winter, the one for the winter time is generally methyl alcohol because it has a much lower freezing point. So when it gets sprayed on the windshield, if you were to spray water or something else on the windshield and it's very cold, it automatically freezes. Whereas methyl alcohol, when you spray it on the windshield, doesn't freeze. So it allows it to act as that cleaning fluid. Other places you might find methyl alcohol or methanol is paint strippers. Antifreeze is usually something else. What's antifreeze? I heard something. Ethylene glycol, right? So they're kind of related in the sense that they're toxic alcohols, but they're not exactly the same. The problem with methyl alcohol ingestion is you have an enzyme in your blood which basically converts or detoxifies alcohol, called alcohol dehydrogenase. So if you're a person who drinks a lot of alcohol, you have a tolerance to alcohol because your body has made more of the enzyme that breaks it down called alcohol dehydrogenase. If you're like me and you hardly ever drink and you go and you have one cocktail, you're blitzed out of your mind because I have like no alcohol dehydrogenase. The problem with methanol is the same enzyme, alcohol dehydrogenase, breaks the methanol down into formaldehyde and formic acid in your body. Is formaldehyde good or bad?
But
Where do you find formaldehyde? In embalming fluid, right? It literally embalms you. And formic acid, if you've ever heard of like certain kinds of beetles or ants, like bullet ants in the Amazon jungle, they literally spray formic acid from their glands, and it burns, causes a chemical burn. So if you drink methyl alcohol, you're embalming yourself and you're giving yourself a burn internally. Probably not good. The formaldehyde also, the eyes are very sensitive to it, and it causes blindness. So the most common problem with a methanol ingestion is blindness. Peak levels are obtained within 30 to 90 minutes after an ingestion. Now, if methanol is broken down by alcohol dehydrogenase, what is something you could potentially give a patient with this kind of an ingestion that might block the enzyme from breaking down the methanol? What is something else that enzyme might act on? Alcohol. So the antidote for methanol ingestion is straight up 100 proof alcohol. So if you can go and buy some Everclear and have them chug it, you're probably going to save their life, right? So that's the like old school way of doing things. The new school way of doing things is there is an actual antidote called fomepizole. Fomepizole also blocks that same enzyme, but it's given through a syringe and an IV. But you could actually give somebody like vodka through an IV, and it would work. So
It's not in our protocol, so don't be doing that.
unless you're going to save their life, in which case, go ahead.
Then you get Dr. Brooke on the phone and you say, "Hey, Dr. Brooke,
Right.
remember that time you said I should give vodka into the IV? Is that okay?"
which is the preferred alcohol to give the vodka? Is it the Absolute or the New Amsterdam? Which?
It's whatever you can get your hands on at the moment.
Yeah.
Whatever they got in their
So I got moonshine.
Moonshine's the best, except it's probably got some metal contaminants or copper or something. Ethylene glycol is similar to methanol in the sense that it is a toxic alcohol, but ethylene glycol, it acts a little bit differently, but it's way worse. Ethylene glycol, one capful can kill you. So if you want to go, that's the way to do it. It's going to be not a pleasant death, but it's almost certain to happen. And the way that you can find out if somebody drank ethylene glycol is they put an additive in the antifreeze that shows up glowing in your urine like a black light. So you can have the person pee and shine a black light on it, and it'll glow. That's not the ethylene glycol itself; it's an additive. But the ethylene glycol will cause things like your liver to fail and your organs to shut down and your kidneys to fail, and it's not great. Yeah, I do too.
Just in the back of an ambulance.
One experience that I personally had was a patient who came in as a trauma. She was found in the woods in a car with about 20 stab wounds to the left chest wall and an ice pick on the floor. And was brought in by EMS, unconscious, unresponsive, and we started working her up as a trauma workup, of course, because she's had penetrating wounds to the chest. and the trauma surgeon's putting in chest tubes and all of this, that, and the other. And we sent off a bunch of labs. Those labs came back very strange. Like, I've seen a lot of people in traumas and a lot of people stabbed, and they don't have like weird potassium and calcium levels and what we call an anion gap. That's where there's too much of the positive ions in their blood. Like, there's a whole bunch of markers in this woman's blood that were just like, this doesn't make any sense at all. So I went to the trauma surgeon and I said, I honestly think this person has a toxic alcohol ingestion because you don't see this kind of blood work in anything but this. And so we took some blood samples, we sent them off to the state lab to check for methanol and ethylene glycol levels. They don't come back right away, and that's not a common test. But the treatment for these types of ingestions is either omeprazole, which is the antidote. But if the person is in such critical condition that they don't really have a whole lot of time to let that omeprazole get into the system and work, what is another really quick way that you can get something out of a person's body if it's in their bloodstream? Dialysis, right? So dialysis is another way of eliminating or detoxifying something from a person's body. And so I called the nephrologist, the kidney doctor, and I said, you got to dialyze this person. And she goes, well, what's their kidney function? Kidney function's normal. We're not going to dialyze them. I'm not coming in the middle of the night to do dialysis. I said, no, you don't understand. I think this person is poisoned, and this is the only way to get it out of the system. Nah, we'll see her tomorrow, right? So then I called the ICU doctor, and I said, do I sound crazy? This is what I'm thinking. And he goes, no, that sounds about right. So I called the nephrologist back, and I said, listen, you're coming in to dialyze this person. I'm going to have the trauma surgeon put a dialysis catheter. You got to get here now, because if you're not here now, this person's dead in an hour. They came in, took her to dialysis. 1 hour after dialysis, every single one of her labs looked perfect, spot on normal, and she woke up. And so when she woke up, well, what the hell did you do? She first tried to kill herself by getting in a bathtub with a toaster oven and shocked herself, but didn't die. She then went into the garage and found whatever bottles of things were in the garage and drank them. And when that didn't kill her right away, she got an ice pick and drove her car into the woods and stabbed herself until she passed out. And so
She was
she
committed.
was very determined.
Can you imagine being so bad that you cry?
It's still scary.
And you still can't kill yourself?
So I went to see her in the ICU a couple of days later, and her family was so thankful. Oh, we're so appreciative that you saved her life. She was
not.
furious. She was like, I really, really, really tried to kill myself. Damn you for saving me. But then finally, a couple of weeks later, the methanol level came back from the lab, and it was like one of the highest methanol levels that anybody's ever survived in. So it's one of those things where if you know what you're looking for and you catch it and you think of it, you can save a life. But if you never think of it and you're not aware of it, the person's going to die. And so this is why having knowledge of these kinds of things can really make an impact, right? If you're aware and you're thinking of it, you're going to recognize it. If you're completely unaware, you can't recognize it. So knowing the toxidromes, anticholinergic, sympathomimetic, acetylcholine inhibitors, cholinergics, when you can recognize those things and you see the patient, it's going to come to your head, hey, I know what this is. This is an anticholinergic overdose because they have all of these symptoms. Now you've made an impact. And you can see that. We're going to skip ahead. The lethal dose of ethylene glycol is about 2 milliliters per kilogram. So if you're a 70 kilogram person, then less than 150 milliliters is lethal. That's not a lot of fluid. So what are the things you might see with an ethylene glycol overdose? Depression of the nervous system. They might appear intoxicated, vomiting, seizures, or even coma. If you don't intervene quickly, they're going to start having respiratory symptoms, high blood pressure, go into congestive heart failure, and ultimately their kidneys will shut down. Not a good way to go. And we talked about methanol poisoning. The tricyclic antidepressants. So they're a kind of interesting group of drugs because mostly we don't really use them any longer. They've been replaced by SSRIs. SSRIs are serotonin uptake inhibitors, reuptake inhibitors that are very, very safe. So most antidepressants are SSRIs. The antidepressants have a lot of problems because they cause cardiac side effects. They affect receptors on the heart, sodium channels, calcium channels, potassium channels. All of those things are bad. So tricyclic antidepressants have what's called a narrow therapeutic index. What is a narrow therapeutic index? Thank you, perfect. A small window that it actually works. So what did we talk about? A poison and a drug are the same thing, it's just the dose. So for tricyclic antidepressants, if you take it at the right dose, it's a drug. If you take it at the wrong dose, it's a poison, and it can cause cardiac side effects. And another thing that has a really narrow therapeutic index is lithium. Lithium, one pill is safe, 2 pills could be toxic. Right? So there are some drugs where if you take 1 extra or 2 extra, it could be bad. Tricyclic antidepressants are one of those groups of drugs where if you take too many, it could be bad. And if you see somebody with dry mouth, blurred vision, urinary retention, and constipation, what do they have? Right, a tricyclic antidepressant overdose, but what does that remind you of? What tox syndrome? Anticholinergic. Right. So tricyclic antidepressants are actually also anticholinergics. So if you were to pick a class of psychiatric medications that are really bad because they're anticholinergic, they have cardiac side effects, it would be the tricyclic antidepressants. An overdose can cause confusion, hallucinations, seizures, respiratory difficulty, heart blocks, tachycardia. Sounds not great. We're going to skip the MAOIs because basically we don't even use them anymore. These were another very narrow therapeutic range antidepressant that basically are not even really on the market. The newer antidepressants have a much better therapeutic profile or a wider therapeutic range. It's pretty hard to overdose on them. These are things like Zoloft, Prozac, Paxil. The one exception to this rule here is Wellbutrin. Wellbutrin is very well known to cause delayed seizures. So if you have a Wellbutrin overdose, that is definitely a patient you're watching in the hospital for at least 24 hours because it is very well documented to cause seizures. Trazodone has a different side effect, which is unfortunate. It basically causes a permanent erection. So,
For forever?
not forever, but for a really long time, like more than you would want. And so, if you ever speak to a urologist, they're like, we hate Trazodone because everybody on Trazodone comes into the office and we have to stick a needle in their penis and do all these bad things. So, Trazodone has its own problematic side effect. Lithium, as I mentioned, is oftentimes used to treat bipolar disorder. Again, a very narrow therapeutic index. What is lithium? It's a metal, right? It's an element. Are most of our drugs elements? Not most of them. I mean, some of them are, right? We talked about calcium, like Tums, right? That's an element. What are some other elements? Magnesium, right? Those are more like supplements, right? So there are elemental things that we ingest, but few of them are used as drugs. Lithium, which is a metal, is used as a drug, but if you take too much of it, it causes your kidneys to fail. So oftentimes when people come in with a lithium overdose, the first thing we're checking is their kidney function. It also can cause problems like confusion, seizures, heart dysrhythmias. The problem with elements is that the most common way we try to detoxify somebody is to give them activated charcoal. Activated charcoal, as we mentioned, is very absorbent. It's like a sponge for chemical compounds. They like to stick to activated charcoal. The problem with elements are single atoms, right? Lithium is a single atom of lithium. They're too small to stick inside the pockets of the charcoal. You have charcoal, if you were to look with a magnifying glass, it looks like little caves. And if you're a big organic compound and you get stuck in that cave, you can't get out. If you're lithium, you're just floating in and out because there's nothing holding you there. So anytime you have an ingestion of anything that's an element, you can't use activated charcoal to eliminate it, okay? So if you can't use charcoal, what is another way that you might want to get lithium out of somebody's body if, for example, they were suicidal and took their whole bottle of lithium? It's anywhere in their system. So dialysis is an option. What's the other option if it's like in their gut or in their intestine or in their stomach? So pumping the stomach is what we call gastric lavage. Gastric lavage is notoriously ineffective. They've done a bunch of studies where they had people swallow dummy pills, blanks, and then they did gastric lavage to see how many pills they get out. And out of 20 pills, they get like 2 or 3. So gastric lavage, not all that effective. So sucking it out the top doesn't work. What's another way? Out the bottom, right? There's only 2 holes, right? The top and the bottom. So there's something called whole bowel irrigation. If you've ever had a colonoscopy and you had to drink a bunch of foul fluid that made you poop your brains out, right? Polyethylene glycol. You basically give somebody what's called go lightly, which really should be called go heavily, right? And it makes you poop. And so if you can poop out all of the pills before they get absorbed, then you're going to have much less of an exposure. So for something like lithium, your options are pretty limited: whole bowel irrigation and dialysis. That's about it. Salicylates. What is a salicylate? One of the oldest drugs known to man. In common terms. Aspirin, beautiful, right? Salicylic acid, perfect. So a lot of people take 81 milligram baby aspirin every day. Right? It has some antiplatelet effects. Salicylates come originally from the willow bark. And so American Indians, if they had a fever, would call it the fever tree because they would strip the bark, make a tea, and drink it. And they were essentially drinking aspirin, right? Which is a pain reliever and an anti-fever medication. And so this is a very old kind of drug. The problem with aspirin is a baby aspirin's not going to kill you. 2 baby aspirins won't kill you. But if you take a whole bottle of aspirin, it's not going to be great. It's going to cause what's called metabolic acidosis. And about 300 milligrams per kilogram is the toxic dose. That's a lot of pills. Most people probably not going to take those many pills. But it's something to consider. And we can test the salicylate level in the blood. So when somebody comes in for an overdose, we send a Tylenol level and we send a salicylate level because we know those are things that we can treat and that are readily available. There is a very, very concentrated form of salicylate called oil of wintergreen, and those are pretty toxic because that is a very high concentration of a liquid, and if you were to ingest that, that could be bad. Where are some other places you might find salicylates besides a baby? Anybody ever heard of mixed vapor rub, icy hot? Like a lot of those kinds of rubs contain salicylates. And so there are some cases of people who are, for example, like marathon runners who were running, were very sweaty, their muscles were sore and aching. They would stop and rub all over their body some like icy hot kind of rub. Because they were sweating and their pores were open, they rapidly absorbed a ton of salicylate and actually became salicylate. So that's another potential way that because aspirin is an organic compound, you can use activated charcoal, and you want to give IV fluids and things like that. Tylenol. Tylenol is the most commonly overdosed on medication, not intentionally. And the reason is because if you have a cold or the flu or you feel bad and you have a headache, people don't realize that the medications they're taking have Tylenol in it. Number one, because it says acetaminophen and they don't know what acetaminophen is. And number two, because they often come as combinations of things. So when you take cold and flu medication, probably has Tylenol. When you take Tylenol for your headache, probably has Tylenol. A lot of these medications have combinations with Tylenol. And so if you take a bunch of different medications for your flu symptoms and they all have Tylenol in it, you can overdose. Now, the toxic cutoff for Tylenol is 150 milligrams per kilogram. And the signs and symptoms come in stages. The first stage of an overdose is in the first half an hour to 24 hours, generally nausea, vomiting, weakness. Within the first day to 2 days, abdominal pain and your liver enzymes might go up. Within 3 to 4 days, your liver shuts down. And within 4 to 14 days, you go into complete fulminant liver failure. The only treatment if you go into liver failure is a liver transplant. And so people who unintentionally take, or I would say intentionally take Tylenol for suicidal thoughts, but are thinking Tylenol's not that bad, Tylenol's really bad. So this especially applies to teenagers. They get angry, their boyfriend broke up with them. Tylenol is readily available. I mean, if you've ever seen a Costco bottle of Tylenol, it's like 500 pills in a giant jar, right? And it doesn't take a whole lot to get to that 150 milligram dose. And so there is a way to actually determine if somebody is overdosed. It's called the Matthew Rumack nomogram. It's basically a big graph, and it starts at 4 hours. The reason it starts at 4 hours is it takes about 4 hours for Tylenol to be absorbed into your system from your gut. And at the 4 hour mark, we check somebody's blood and we measure the level. And if the level is over 150 milligrams per kilogram, they're at a toxic dose and they're at a high risk of liver failure. And in that case, we have to treat. If they're below 150 milligrams per kilogram, they're at a low risk of liver failure, and generally we will just watch them and do nothing else. Now the key here is the timing, because you have to take that blood measurement at 4 hours. Well, if I don't know when you took your ingestion, it could be 4 hours, 8 hours, 12 hours, 24 hours ago, I don't know. So in those cases, we usually err on the side of treating the person, because the worst case scenario is they go into liver failure and they die. The best case scenario is you spend a couple of $1,000s treating them and they get better, right? So in this case, treatment is always the safe way to go if you're unsure. But if you're very sure, the person says, I took exactly 16 pills and I know exactly when I took them, you can calculate it out on this graph and determine whether they need treatment. The treatment comes in two forms. It's called N-acetylcysteine or NAC. Some people use it in bodybuilding, health benefits. It replenishes the detoxifying part of your liver called glutathione. Glutathione is a compound made in your liver that generally detoxifies things. What is your liver's normal function? Detoxifying things, right? So when you ingest something and it's a toxin, your liver detoxifies. So the way that the N-acetylcysteine works is it replenishes the glutathione that allows your body to detoxify the chemical. If you run out of glutathione, you can't detoxify the chemical anymore, And so what happens is in the liver, the Tylenol becomes a toxic metabolite if you cannot detoxify it. The N-acetylcysteine comes in two forms. It comes in an oral form, a pill. It comes in a IV form, in a bag. The IV form is 3 different doses over 24 hours, and it costs about $5,000. The pill form, you have to take a pill like every hour for 72 hours, which is unpleasant, and it costs about like $5. So if you were the person just, giving this antidote, would you give the pills or would you give the IV form? No right or wrong answer. IV because it's easier to remember? Sure. Right. Anybody else? I mean, that's a pretty big price difference, right? $5, $5,000. But the real cost here is the patient has to be in the ICU. So if you had to be in the ICU for 1 day or you had to be in the ICU for 3 days, which do you think costs more? 3 days in the ICU is like $60,000, right? 3 days, 1 day in the ICU is $20,000. So if you add it up, the $20,000 to stay in the ICU and the $5,000 medication is significantly less than staying in the ICU for 3 days taking a pill every hour. So even though the medication, the antidote, it is an antidote, N-acetylcysteine or NAC is the antidote for Tylenol or acetaminophen. Remember that. But the IV form is generally given because even though it's expensive, it's much more rapid. Most other kinds of pain medications, like non-steroidal anti-inflammatories, are generally not that toxic. They can cause kidney problems in higher doses, or if you're somebody who already has kidney problems to begin with. So generally you want to stay away from things like Motrin, naproxen, ibuprofen, Advil if you have kidney issues. The other potential problem is it causes gastric ulcers. So oftentimes these medications affect the way that the acid pumps in your stomach lining work, and you can end up with an ulcer. But for the most part, they're pretty safe, right? If you took a whole bunch of Motrin, you might get nauseous. Probably that's about it. If you take a whole bunch of Tylenol, you go into fulminant liver failure and you die, right? So most people think Motrin is the much worse medication. It's really the much safer medication. Theophylline, I won't really touch on too much, but it's related to caffeine. It is a very old school drug, and it's used for asthmatics as a bronchodilator. If you are a very old school doctor, you still prescribe theophylline to your asthma patients, but it causes severe cardiac irregularities. So these patients oftentimes will die of like a ventricular dysrhythmia or something like that. So for the most part, you don't see theophylline anymore, but it comes from the cacao, which is the chocolate bean, right? So it's kind of related to caffeine, how caffeine comes from a coffee bean. Theophylline comes from a cacao bean or chocolate bean. So when you eat chocolate, you're actually taking very small doses of theophylline in the chocolate. Iron, safe or not safe?
Taking in the right doses.
Right. So just like everything we've been talking about, iron in the right dose can help you build your hemoglobin and your blood iron levels, and that's good. Iron in high doses very, very, very bad. Causes shock, bleeding from your gut, liver failure, bowel obstruction, bad. So most of the time we find high iron doses in prenatal vitamins because pregnant patients are trying to build up their blood system to support having a pregnancy. So oftentimes if somebody overdoses on vitamins, and it's just a regular everyday once a day vitamin with a normal or low dose of iron or no iron, Vitamins generally are pretty safe. So you can take a lot of, Flintstones vitamins, and nothing bad's gonna happen. But if you take a whole bottle of prenatal vitamins, bad news. Is iron a chemical? What is iron? It's an element, right? So can you give activated charcoal to absorb it? No. So the only way you're gonna get iron out of the body is whole bowel irrigation. So go lightly, drink it, flush it out, right? Lead and mercury, what are they? Elements. Activated charcoal. Where do you find lead? Paint before like 1978, right? So if you've ever bought a really old house or been in an old house, they actually make you sign a waiver saying that you're buying this house and you know that you're going to get lead poisoning and it's probably going to cause a bunch of neurologic effects and your child might be born with a low IQ and you're going to have all of these problems. And you go, okay, and you sign off on it, right? Because I like old houses. So and a lot of times they have to do remediation. Remediation literally means putting the house inside of a tent and having people come in and sandblast and strip all of the lead paint off of the walls and out of the house. So old houses, probably not the way to go. What else might you find in old houses that's not so great? Asbestos, right? Causes cancer and scarring of the lungs. So you're going to be neurologically damaged and you're going to have lung scarring. Sounds like a good idea, right? Mesothelioma. Arsenic. Arsenic is another metal. Arsenic, good or bad? Bad. Arsenic, like cyanide, causes problems with your electron transport chain and causes your cells to rupture, your muscles to break down, your blood pressure to drop. Where's one place that arsenic is fairly common, actually? No, they don't use it in rat poison. Well water. So you have to be really, really careful. People who have wells have to get their water checked pretty frequently because arsenic is a common mineral in the soil and it can leach into your well water. So that's something that so I just want to touch on some things related to drug use because there's different terminology which would be important to understand. A drug of abuse or an overdose is a medication used for a purpose other than a medical reason. So is it possible to overdose on THC, on cannabis? Yes, no? You can overdose on anything. You can overdose on water, right? So yeah, you can overdose on cannabis. I see it at least once a week because the THC gummies have 200 milligrams of THC in them, and you're supposed to take like one little paw off of the gummy bear and eat that, right? But grandma sees gummy bears in the fridge and grabs a handful of them and pops them in her mouth and comes in literally out of her mind, like vomiting, holding her stomach, hallucinating, crawling on the floor, meowing like a cat, right? So you can overdose on anything. When you have a drug problem, you can have addiction. Addiction is when you want or crave the drug. You can have habituation. Habituation is where you become basically used to having the drug in your system. And so it's like the alcoholic who's a functional alcoholic, right? They drink every day, they're habituated to it, and yet they still are functional. There's a physiologic and psychologic dependence. So when you go into withdrawal, you're addicted to benzos, you take your benzos every day, you run out of your benzos. There's two components. Your body is telling you, I need benzos, right? And you're agitated and you're anxious. Your brain is thinking only one thing. Get me my benzos, get me my benzos, get me my benzos. Right? So there's the dependence that's a psychological dependence, I need it to function, and the physiologic dependence, I need it to function. There's tolerance. Tolerance is especially important when it comes to opiates, because if you're a person who uses opiates or abuses opiates, your body becomes tolerant of them by downregulating the receptors that it attaches to, and you need more of it to get the same effect. And so the person who starts off taking a Percocet or an oxycodone after surgery, and it goes, wow, this feels really good. And then after a couple of days, it's not working. So now they take 2 of them and they go, oh, I feel really good again. And a couple of days later, it's not working and they take another. Now they're taking 3 at a time. So this is a problem of tolerance. Tolerance is your body adapting to the drug and needing more of it to get the same effect. So habituation is your body getting used to being on something. Tolerance is your body actually needing more of it to get the same effect. Withdrawal we talked about. Withdrawal is literally the opposite of whatever the drug did to you, is those symptoms. And an overdose is an excessive amount of the drug. Usually intentional, but not always. So there's always the psychosocial issues. When people come in and you tell them, you should stop smoking cigarettes, what do they tell you? They said, I quit. And I said, oh, great. When did you quit? 5 minutes ago, right? Because it's nearly impossible to quit. Your body is used to having this thing, but it's not only the thing itself, the nicotine, it's the physically holding the cigarette in your hand, putting it up to your lips, being in a social situation where people are smoking. There are so many other elements to using these drugs, whether it's heroin, cocaine, whatever it is. There's the psychological component and then there's the psychosocial component. Most of the time, the only way to get somebody to quit using something is to literally take them out of their environment. And so when you have somebody who's a heroin user who lives in New York City and you say, we're going to put you on a bus and send you to Alabama. They get to Alabama and they stop using and they're fine and they get help. And then their family says, hey, you got to come home and come back to New York. And they come back to New York. And the minute they're back in that same environment they were in before, they immediately go back to using it. So there is a very strong psychosocial component to use. Long-term drug abuse can cause damage to brain, liver, heart, malnutrition. Common drugs. We talked about alcohol, #1 worst drug ever created, and the most legal drug there is. Right? More people die of alcohol intoxication, alcohol poisoning, driving while intoxicated, shooting themselves while intoxicated, jumping off a bridge while intoxicated, falling into a pool while intoxicated, overdosing on their meds while intoxicated. Right? Alcohol is the killer. And yet it is totally legal because why? There are some corporations making a lot of money, right? Barbiturates, not a whole lot of people on barbiturates. I don't think I see really anybody on them except for people with really bad seizures. Might be on phenobarbital. But if you were a guy in the 70s going to Woodstock, you probably had some barbiturates and quaaludes and a bunch of stuff that we just don't see that often. Cocaine, super common. Is cocaine, is it a stimulant? Is it a depressant? Is it a stimulant, right? So the class of drugs called stimulants, we also call sympathomimetics. The word sympathomimetic has to do with the flight or fight part of your neurologic system. So when you gotta run from a lion because it's chasing after you, your sympathomimetic nervous system kicks in and you've got super strength, you've got super speed, you've got super hearing, you've got supervision, because everything is revved up and ready to be able to defend yourself, right? So your heart rate increases, your pupils become dilated, and you're ready to go. Are the narcotics depressants or stimulants? Definitely depressants, right? The biggest problem, respiratory depression. What is the cutoff for how many breaths per minute would concern you if you saw somebody who had taken a bunch of narcotics? If they're breathing 20 breaths a minute, is that concerning? How about 16, 12, 10, 8? Yeah, I like 8. If I walk into the room and I'm watching the person breathe and they're going like this, like that, I'm like, uh-oh, bad news bears, right? They're getting some Narcan. If I walk in the room and it's an opiate overdose and they're breathing a normal 12, 15, 16 breaths a minute, I leave them be. They're fine. They're breathing. Their vital signs are okay. What happens when you give somebody Narcan? You force them into what? Withdrawal. What's the withdrawal from Narcan, from opiate? The opposite. The opposite of bowels not moving, sluggish, lying there, barely responsive, is vomiting and puking all over you, agitated and increased heart rate. So if I can manage a patient without putting them into withdrawal, I'd rather they be asleep and stable than vomiting in my face, right? So if they're breathing more than 8 breaths a minute, I leave them be. If they're breathing 8 breaths a minute or less, I give them a touch of Narcan just to get their respiratory rate up. If they look like they're about to crap out and die on me because their blood pressure is 40/20, I give them as much Narcan as it takes to wake them up. Okay? So you don't have to go gung-ho on giving people Narcan in the field. You just get their respiratory rate up, get their vital signs stable, and bring them in, and we'll happily watch them. Is marijuana a drug? What's the side effects of marijuana? Does it have any side effects? Dry mouth, red eyes, those aren't too bad.
Anxiety.
Could give you anxiety, could give you an increased heart rate. Yeah, a little bit off motor function. The worst problem with marijuana, and people don't really understand this, is that the marijuana, the THC content of marijuana in the 1970s, when it was very popular to smoke marijuana, was somewhere between 4 and 7%. The THC concentration of the marijuana we grow today in marijuana farms to sell in marijuana dispensaries is 22 to 26% THC. So that blunt that you smoked in the 70s that you could smoke all day ain't the blunt of today, which is 8 times more marijuana THC active component in one single cigarette. And so people who are smoking frequently, we have receptors for THC not only in our brain, in our stomach and our gut is the other place where there's a lot of receptors for THC. So there's a phenomenon called cannabinoid hyperemesis syndrome. People who smoke marijuana every day vomit all day long and all the time, and it doesn't stop. And you can give them Zofran and antiemetics and all of this, and it doesn't work. And so they go to tons of doctors. They go to the gastroenterologist, and they go to the psychiatrist, and they go to the primary doctor, and nobody can figure out why they're vomiting all the time. And they come to the ER, and I go, do you smoke marijuana? And they go, yeah. And I go, how much do you smoke? And they go, all day, all the time. And I go, well, your treatment is stop smoking marijuana, right? Like that's the only thing that's going to stop them from vomiting. And so I don't think people really realize that marijuana is generally safe, but if you smoke too much of it, like anything else, it's a drug and it's a poison, right? Amphetamines, are they sympathomimetic or depressant?
Pathomimetic.
Sympathomimetic, they speed things up, just like cocaine. Are hallucinogens sympathomimetic or depressants? They're neither, right? They're just hallucinogens. So hallucinogens make you feel disoriented or disconnected or have an like out of body experience or cause you to hallucinate. And these often work on the serotonin receptors in your brain. So things like LSD, ecstasy, often work on serotonin. And what is serotonin? A happy neurotransmitter, right? When you want to feel good and you eat chocolate, chocolate upregulates your serotonin. When you feel like you're feeling a little sexy with your partner, what's happening? Your partner's giving you a back rub, a kiss, a hug. Your serotonin's going up. When you're doing LSD or ecstasy, your serotonin's going up. So it's your choice, chocolate or LSD. The sedatives include things like the Ativans and the Valiums and the Xanax and the barbiturates, and these generally cause things to slow down. They're depressants. And is it possible to overdose on a benzodiazepine? Sure it is. Are there reversal agents for benzodiazepines? Yes, no, maybe. Say it loud. Bromazicon, right? So there is a reversal agent for benzodiazepines. The one thing I would warn you of is that people who are habituated to benzodiazepines or they use them every day and all the time, if you reverse it, what happens when you reverse something? You get the opposite. And what is the opposite of a depressant? Stimulant. And what if you have too much stimulation in your brain? Seizures. So if you reverse somebody who's normally taking benzodiazepines, you will give them seizures. And what is the normal treatment to give somebody if they're seizing? Benzodiazepines. Well, is it going to work if you just block the benzodiazepine because you gave them the antidote? No. So you just put yourself in a really terrible situation, right? So the only time I would ever recommend reversing a benzo is in somebody who's naive or has never been exposed to a benzo before, who's having a side effect. So if you get to a house and there's a 3-year-old who's got respiratory depression and looks altered and is lying there limp, and mom's Ativan is spilled on the floor, that would be the appropriate time to give a reversal agent because that child is not going to seize when you reverse it. That child's naive to the benzo. Okay? Anybody ever heard of bath salts? Yeah. Bath salts are in those sympathomimetic, that like cocaine category of stimulants. And they call them bath salts because they're often like crystals that you can buy in packages at gas stations. It's actually a drug called methcathinone, and it can cause paranoia, hallucinations, agitation. Ketamine. Anybody ever heard of ketamine? What was ketamine originally used as? A horse tranquilizer. Do we use it as a horse tranquilizer? Thank you very much. It depends on how big your patient is. So we use it as a tranquilizer for people with agitated delirium. So in a person who you cannot really get very good control over, it is a drug which causes dissociation. Dissociation, like a hallucinogen, makes you feel like you are out of your body. And so you feel disconnected from reality, which could be good or could be bad. The good thing about ketamine is it does not affect your vital signs. So unlike other kinds of depressants, so you give somebody benzos, it could drop their blood pressure. You give somebody a phenobarbital, it could depress their respiratory drive. You give somebody ketamine, it really doesn't touch their blood pressure, their heart rate, their oxygen, or their breathing. So that's why we like ketamine, because it's relatively safe, even at high doses, right? At low doses, ketamine actually has pain control aspects of its function. So sometimes if somebody, for example, broke an ankle, we can give them a really low dose of ketamine, not a microdose, but a low dose, and it will take the pain, alleviate the pain, but it won't cause them to be altered. And if you give them 5 or 6 times that amount, they basically are like happy. They're like in La La Land. Very good for kids. When we have to sedate kids, we like ketamine as an option. The only problem with ketamine is you can have what's called a reemergence reaction, which is as you're coming out of the ketamine, you can't really tell whether you're in reality or in some other place, and a lot of people will freak out. And so we'll use something else like some propofol or some Ativan or something else to kind of reduce that reemergence reaction. But it's really funny. If you've ever given somebody ketamine and talked to them, they will tell you the funniest shit you've ever heard, like, oh, I date your mom, or, like just some wackadoo stuff because they are completely like disoriented from reality. You can abuse ketamine and people buy it on the streets. When it's used as in abuse, it's called going in the K-hole. And really, there's not much to do. Support their airway, breathing, and circulation, give them some oxygen, establish some IV, and give them some fluids. Anybody familiar with peyote or mescaline? Where do you find those? Desert of the southwest of the United States and Mexico. And the peyote is actually, you see those little white buds there? Those are glands on the cactus, and the glands is what actually makes the chemical. So you just pop the little bud off, put it under your tongue, and let it absorb, and basically will cause hallucinations. American Indians, especially like shamans and things like that, would use these kinds of chemicals to kind of go into another state, like an out-of-body experience to try to communicate with spirits. Ecstasy we often see at like rave parties and things like that. The problem with ecstasy is it causes you to sweat a lot, your blood pressure to go up, your heart rate to go up, and if you're in a club in a tight space and you're partying all night, you're probably not drinking a lot of fluids, and so we oftentimes see these people coming in with actually drug-induced fever, severe dehydration, and very high sodium levels. And so the problem with ecstasy is most often they really need a lot of fluids. So if you see somebody who seems like they're altered and has a fever and they were on that, give them fluids. Get them anybody heard of Rohypnol? Right, a date rape drug. It's related to benzodiazepines, so it's related to sedatives. So when you give it, mix it in a drink or whatever, the person after X amount of time basically passes out and is like semi-conscious. So this is if you're not familiar with all the uppers and downers, this is a good guide for you here.
Question.
Yeah.
The Daedric drug, is that the same thing that's inside of Visine? That they put into alcohol to spike your brain?
I don't think there's any benzos in Visine. Anyways, what was I saying? Oh, just, these things come in all shapes, sizes, colors, forms, powders, pills, bags. You can print them, press them, ash oil. Like, these things come in pretty much any kind of form. And humans are very creative, right? Like, we make sticky stamps out of LSD, and you lick the stamp. Opium, where does opium come from? Poppy plant, right? So if you ever have to take a drug screen, don't eat your poppy seed bagel the day before, because you will test positive. Not really. It depends on how sensitive the test is. But like the state drug labs, even just a poppy seed bagel will make you positive. They can get like nanogram per deciliter. You guys want to take a break for a minute and stretch? I know I've been talking for quite some time. Yeah, take a 5-minute break.